right, so we're going to begin the webinar. Welcome everyone to the Tobacco-Free RNA webinar. I have no time, supporting the integration of tobacco intervention into acute care settings. My name is Tasha Penny, and I am the Implementation Manager for the Mental Health and Addiction Initiative at RNAO, and I will be moderating today's webinar. RNAO is the professional association for registered nurses and nursing students in Ontario and promotes excellence in nursing practice and advancing nurses' contribution to the healthcare system. RNAO has a signature program called the International Affairs and Best Practice Guidelines Center, so we just call it IABPG for short, that develops, disseminates, implements, and evaluates clinical and healthy work environment best practice guidelines. So the Tobacco Intervention Initiative is one program within the IABPG Center. The focus of the Tobacco Initiative is the newly revised and published Best Practice Guideline integrating tobacco interventions into daily practice. As part of our Tobacco Intervention Initiative, we hold regular webinars to support building capacity among nurses and other health workers to implement and sustain best practices in regards to intervening with people who use tobacco. So just as I mentioned earlier, if throughout the webinar you have any questions or comments, please type them in the chat box. And we'll also aim to have the last 15 minutes of the webinar just for questions, for a question period. So we'll also be archiving these slides on our tobaccofreerno.ca website, so they are available for future viewing. And now I'm just going to introduce our speaker. Her name is Nicole Jeffery. Nicole is an implementation specialist with our Tobacco Intervention Initiative. She completed a Master's of Nursing program at Ryerson University and has worked on various research projects focusing on addressing the social and health needs of newcomers to Canada, reducing loneliness for persons with dementia, and the international standardization of nurse practitioner education. In addition to her research work, Nicole has worked as a nurse in a variety of settings, including med-surg units, gynae-oncology units, and most recently the emergency department, where she continues to work as a staff nurse. Nicole is passionate about incorporating the best available evidence into clinical practice in order to improve patient outcomes and the impact that we as healthcare providers can have to motivate people to make positive changes for their health. So just before I turn it over to Nicole to start the presentation, just a reminder that you need to turn up your speakers if you're having trouble hearing any of the audio. And as I mentioned, we're being recorded, okay? So now I'll turn it over to Nicole to start the presentation.
Thank you, Tasha. So my name is Nicole. I've been a member or a staff member at RNAO for the last 3 months within the Tobacco Intervention Initiative. I just want to mention one thing before we start, is just that when you type messages into the chat, there is a scroll down menu so you can see whether your message is going to all participants or just to the host and the presenter. So just to keep that in mind when you're putting your questions in, whether you want it to be just for me or you want the group as a whole to see everything that you're typing in the chat box. So thank you again, everyone, for attending today and for registering for the webinar. I just want to start by saying that my experience within nursing has mostly been within the acute care setting, and this is the implementation of tobacco interventions. The implementation of tobacco interventions into acute care settings is a gap that I personally have found while working within acute care centers, and it's not something that we address enough or that we're doing on a continuous basis, and this is something that we need to strive to be doing in our everyday routine practice in order to benefit our patients to the fullest extent that we can. So the objectives for the webinar today are to review the impacts of the Smokefree Ontario legislation, to identify guideline recommendations that support tobacco interventions within an acute care setting, and to explore the positive influence of smoke-free hospitals on patient and population health outcomes. So we wanted to have this webinar now just in preparation for the changes in legislation that are going to be occurring as of January 1st, 2018. So this is something that a lot of hospital organizations and settings have been preparing for the last couple of years. Some hospitals I know have already implemented smoke-free policies, but this is something that is effective as of January 1st, 2018. So just to give you a little bit of background on the Smokefree Ontario Act. So the latest version of the Smokefree Ontario Act was implemented in 2006, and this was created largely in response to the World Health Organization's Framework Convention on Tobacco Control that was created in 2003 and have been looking for member countries since 2003 and was created in response to the global tobacco epidemic that has been occurring worldwide. So the Smokefree Ontario Act includes regulations on the provision of tobacco to persons under 19, display and promotion of tobacco products in retail environments, the prohibition of sale in designated places. So this includes things such as how closely we are able to have tobacco products sold within school zones, some places like that. We look also at the packaging, health warnings, and signs of tobacco products, flavored tobacco products, reports from wholesale and distributors. So distributors of tobacco products need to be reporting back to the government the amount of sales that they are doing each year. Controls related to smoking tobacco, prescribed products and substances, and traditional use of tobacco by Indigenous persons. At the end of the presentation, I have included some additional resources and links if you would like to look at the Act in further detail. So some memorable revisions that I just wanted to bring up regarding the Smokefree Ontario Act is a revision that was done in 2007 regarding the residential care facilities. So you must not smoke in residential care facilities. They are considered both an enclosed public place and an enclosed workplace. However, some residential care facilities may choose to construct and operate a controlled smoking area. A residential care facility must have its controlled smoking area approved and registered within the Ministry of Health and Long-Term Care. So within the Smokefree Ontario Act, residential care facilities as well as hospitals and psychiatric facilities are addressed separately within the legislation. In the legislation, it currently states that the grounds of hospitals and psychiatric facilities must be completely smoke-free by January 1st, 2018. So I interpreted that as they are under separate legislation than the residential care facilities. So whether or not this guideline or this section of the Act applies to residential care facilities is something that I'm still continuing to look into, and as soon as that becomes clear to me, I can send out some further information on that as well. Sorry, we're just going to pause for 1 second because it appears that some people are having some issues with the sound and with it cutting in and out. So I just want to make sure that everyone can hear everything that we're saying. So we're just going to pause for just 1 second.
Hi, everyone. So sorry, we're just going to do another audio test. If you can please write in the chat box whether or not you can hear us. And if it's still sounding choppy, please let us know. Okay, great. So it's not cutting in and out, just confirming that it's clear and everyone can hear me fine? Wonderful. Thanks so much.
Okay, so we are going to continue on. So just looking again at the revision that we are here today particularly to talk about. So this is that the grounds of hospitals and psychiatric facilities must be completely smoke-free by January 1st, 2018. So what does this mean for hospitals and for healthcare facilities? So as of January 1st, 2018, there's going to be no smoking anywhere on hospital property. So this involves the removal of designated smoking areas anywhere within hospital property. So the responsibility of healthcare facilities is to give notice to staff, patients, and visitors that no smoking is going to be allowed on hospital grounds. So this involves the posting of no smoking signs, as well as having ashtrays or similar items, ensuring that no ashtrays or similar items are found anywhere on hospital grounds. So one thing that I encountered a lot in practice, especially with the rollout of a policy such as this, is what are the boundaries in which people can smoke and cannot smoke. So this is something important for hospital administrators and for management to clearly designate and give out a clear message to all healthcare providers so that everyone is able to be consistent and give the proper information to all of the patients or even staff members or whoever wants to be using tobacco products on site. So now we're going to be going into some of the immediate and short-term impacts of smoke-free legislation. So the main premise behind having smoke-free legislation is the reduced exposure to secondhand smoke. So secondhand smoke is the second leading cause of cancer worldwide, or in Canada and worldwide. And so the premise behind doing this is just to eliminate the secondhand smoke exposure to non-smokers as well as to other smokers as well. So smoke-free legislation has shown to increase quit attempts by tobacco users as well, and a lot of research actually shows that tobacco users are in support of smoke-free legislation as well. So for tobacco users, smoke-free legislation helps with less accessibility to tobacco products, is also associated with less temptation to use tobacco products, and greater availability of safe places. And this is particularly important for people who are hospitalized. They're already, for the most part, potentially seeing results from their smoking use and are more encouraged to be reducing or quitting their tobacco use, and just to provide them a safe space within the hospital environment to be able to be less tempted by smoking is a positive thing for smokers as well as for non-smokers. Smoke-free legislation also helps with less uptake of tobacco by youth and contributes to the denormalization of tobacco use, or in other words, the decreased socialization of tobacco use. So what does this mean for the healthcare providers who are providing care within the acute care settings where these smoke-free policies are going to be taking place? This means that it's important that healthcare providers who are delivering frontline services to patients are knowledgeable about nicotine and tobacco. So this means knowing about the different harms of tobacco when they're advising their clients, as well as knowing the impacts that tobacco and nicotine have on health and have on the body. This also means that healthcare providers should be incorporating evidence-based tobacco interventions into practice, and that's primarily what we're going to be discussing today throughout the webinar. Healthcare providers should also be knowledgeable about the management and identification of symptoms of nicotine withdrawal. So what are we going to be looking for in our patients in order to manage their symptoms? And this doesn't only mean looking at nicotine replacement therapy, but managing the symptoms of the nicotine withdrawal as well. So are the patients becoming irritable? Are they anxious? Do they have a headache? Do they feel nauseous due to their nicotine withdrawal? Being able to manage those symptoms as well as providing them the nicotine replacement therapy or the pharmacotherapy that they've been using to manage their withdrawal symptoms as well as being knowledgeable about how soon after their last cigarette or last tobacco use they could go into symptoms of withdrawal. So having all of this knowledge to be able to properly care for our patients is important in the implementation of these smoke-free policies. So some of the resources that healthcare providers can use in order to educate them more about the use of tobacco interventions in their daily practice is, of course, the best practice guideline that was published in 2017, and it has all the up-to-date research on how healthcare providers should be engaging with their clients and implementing tobacco interventions. Also just want to point out the toolkit. So today we're going to be talking about the different practice, educational, and system or policy recommendations, and the resources within the toolkit will help you to actually implement these recommendations within your practice. We also have a pocket guide, which can be used as a bedside tool for healthcare practitioners, just to refresh them on brief interventions or on harms from tobacco, and that's something that we are currently revising at present and are hoping to get out to you all as soon as possible to align the pocket guide with the newly published BPG. We also have webinars, so if you go to our tobacco-free RNAO website, we have archived webinars that have been done previously. The webinar that we're doing today will also be archived on the website. We also have e-learns looking at specific populations, and we are currently in the process of revising our core e-learns to align with the new best practice guideline as well. In regard to the RNAO Champions workshops, in the next couple months, the tobacco intervention team is going to be putting out some event flyers, just letting you know that we are going to be hosting 4 workshops within the 2017-2018 fiscal year that anyone champion or RNAO members or not are allowed to attend for free. So as mentioned previously, we're going to be looking at the different practice, educational, and system recommendations. So the way that I am going to facilitate the presentation is I'm going to tell you about a new recommendation, and then we're going to look at how we can apply it to practice. And the application of these recommendations, especially in acute care settings, something that comes up a lot is how am I going to find time to do this new recommendation in an already very workload-heavy environment. So just want to get across the point that the application of these recommendations is to help preserve our time and not to create more workload for the nurses or any frontline staff who's going to be implementing these recommendations. So the first recommendation that I want to discuss with you is recommendation 1.1. Use brief interventions to screen all clients for all forms of tobacco use and initiate intervention as appropriate. So for acute care settings, this recommendation is probably going to be the one that gets implemented across the board, in that brief interventions are only meant to last 1 to 3 minutes and have been proven effective to help people increase their quit attempts and to decrease their tobacco use. So I just want to show you guys a brief intervention flowchart that was created within the new best practice guideline. This is found on page 21 of the new guideline. And during the creation of the new BPG, we were getting a lot of questions around what number of A's are we going to be recommending to the healthcare providers who are going to be using this document. And our response to that was, we don't want to be advising just our healthcare providers to use 3 A's, 4 A's, or 5 A's. We just wanted to get the point across that any brief intervention is better than no intervention. So the brief intervention flowchart that we put together provides practical ways that healthcare providers can approach and engage with their clients and brings them through the process of a brief intervention that could happen between healthcare provider and client or patient or resident or whomever you're engaging with. And it also flows through inpatient as well as community settings, and that was a gap that was identified in the previous guideline that we wanted to address and provide practical examples for both settings. So I know that looked like a lot of text, so I just wanted to zoom in and show you guys a little bit closer up what this brief intervention chart looks like. So the first thing that we want to be doing with our client is asking them about their tobacco use. So have you used any form of tobacco in the last 30 days? And we're going to be discussing in the next section when can we be applying these recommendations. And then another quote that I just want to point out that we have as a guideline for healthcare providers discussing with their clients, especially in the acute care setting, is the best thing you can do for your health is to quit. While you are admitted, you will not be able to use tobacco the same way as when you are at home. So we can work together to manage your withdrawal symptoms. And then also you could ask your client, are you interested in working towards managing your withdrawal symptoms while you are admitted in hospital? So just engaging with those clients while they are admitted in an acute care setting. Also just wanted to point out that you can discuss with your clients whether they are not ready to quit or whether they are ready to quit or manage their symptoms. But within the not ready to quit section, that's the area that I would like to focus just for right now. And just to keep in mind that even if a client is not ready to quit, we should still be advising them about the harms of tobacco and providing them with the resources if in the future that is something that they would like to do. So the brief intervention flowchart brings you down both sides of the spectrum. So application of the recommendation. When can brief interventions take place? The roles and responsibilities of the healthcare providers, documentation, and then knowing your organization. So when can brief interventions take place? This is very setting specific. So in the emergency department, where I currently work, we have been doing the brief intervention at triage. And brief interventions as well, one person can start the brief intervention and the next person can finish it. So it's really just important to make sure that we're asking the question, have you used any form of tobacco in the last 30 days? So that question happens at triage, and then it gets passed on to other healthcare professionals inside who can address whether or not they are ready to quit, but at least we know when we are first approaching our clients whether withdrawal management is something that we need to be considering with this client, how long are they going to be in the emergency department for, and should we be recommending any further treatment to these clients. And so going into the roles and responsibilities, who is responsible for providing brief interventions to clients? And this is something that I think has primarily, especially in acute care settings, been fallen into the roles and responsibility of the physician, because I know in a lot of healthcare organizations, the infrastructure is not there in order for nurses to be able to manage withdrawal symptoms on their own. So that's something that I'm going to be speaking to later in terms of medical directives. But the role and responsibility of providing brief intervention is really on all health providers who are providing direct care to clients. So this could be respiratory therapy, this can be occupational therapy, physiotherapy, nurses, social work. Everyone has the ability to ask clients about their tobacco use and at least refer them to further resources. And that is something that doesn't need to take a lot of time at all. In the emergency department, I know sometimes things happen very quickly, and at least providing them a phone number for someone they can follow up with or information on how they can get access to NRT can go a long way and only takes up to, I would say, just ask and refer would be less than probably a minute to address that with your client. And then just ensuring that we have the appropriate documentation in place and that we are reinforcing with our staff the importance of documenting tobacco status, whether or not they use tobacco, and whether or not an intervention has taken place. And then just in terms of knowing your organization, just finding out, I know in acute care settings especially, we often work in silos, so there isn't a lot of interaction between units. Just finding out what is currently being used within the organization. Do any other units use any form of documentation tool or brief intervention tool, just to make sure that everyone is doing things the same way, and making sure that we're consistent within our healthcare organizations. And just if any tools have been created, just so that we're not reinventing the wheel and creating more work for ourselves, just making sure that we're being as efficient as possible in the implementation of these recommendations. And then also just knowing what resources are available in your organization do we have any smoking cessation programs? Do we have any partners or affiliations with any community partners that help with even providing NRT or counseling, any counseling information? So moving on to practice recommendation 2.1. So develop a person-centered tobacco intervention plan with the client. So before we deliver any of these interventions, we need to explore any personal beliefs or biases that we have about tobacco use prior to doing any of these interventions. So just to make sure that we aren't harboring any negative feelings about people who use tobacco, and if people, while they're in hospital, decide to continue their tobacco use, just to make sure that we know how we feel about that and that we can support our patients and treat them equally. We have some resources here at RNAO to help you explore any feelings that you might have towards tobacco use and to help you facilitate therapeutic relationships and person-centered care. And those are the two guidelines that I have featured on the slide here. Also, just keeping in mind that the social determinants of health do impact our clients' tobacco use and is a large coping mechanism sometimes to deal with these things. And just to keep that in mind, and that might be something that you're addressing before you address their tobacco use. And this is more geared towards people who are going to be staying long-term in the hospital. I know in the emergency department sometimes that's not something we always get around to discussing if we're looking at an acute situation. Okay, so recommendation 3.1, provide clients with or refer them to intensive interventions and counseling on the use of pharmacotherapy if they use tobacco and express an interest in reducing or quitting their tobacco use. So the main point that I wanted to get across with this recommendation is that we can't expect all health providers to have the knowledge, skill, and judgment to be providing intensive interventions on the use of pharmacotherapy or counseling techniques with all of their patients. Healthcare providers should only be implementing interventions that they have the skill to be able to do. So at minimum, all healthcare providers, again, need to just be asking and referring them out if they don't feel comfortable with that recommendation. So I have up here Smokers Helpline. So this is a phone number that can be used, and this is sort of the minimum that we want to be doing with each of our clients. So Smokers Helpline can offer them smoking cessation and tobacco intervention counseling. I also wanted to bring up opt-out strategies. So opt-out strategies is new research that's coming out of Kansas University, and it just illustrates that the assessment portion of brief interventions doesn't always need to necessarily take place in order for tobacco interventions to be effective. So while being person-centered, it's important that we approach situations in a strategic way to be able to get them the information that they need. So anytime you ask anyone about their tobacco use, just say, why don't I provide you with some additional information about how you can quit if that ever becomes an option or ever becomes something that you would like to do, as opposed to saying, would you like these additional resources? So just being strategic about the way we approach these things, and opt-out strategies have proven to increase quit attempts with people who are not ready or willing to quit at the time that they had the interview with the healthcare provider. So motivational interviewing is a counseling technique that has proven to help people address ambivalence to change and has proven in conjunction with other tobacco cessation strategies to increase quit attempts and to help people to quit and to stay quit. So I just wanted to let everyone on the line know that RNAO is going to be hosting a motivational interviewing workshop on November 7th and 8th in Toronto, and I've provided the link to go to the registration for the event on the page, and I can circulate the slides afterwards so that people can click on the link for themselves if they would like to sign up for the workshop. Okay, so moving on, practice recommendation 4.1. So evaluate the effectiveness of the intervention plan until the client's goals are met. So this is looking at the specific plans and evaluating the plans that we've created with the client. We are also going to be looking later on within the system policy and recommendations about evaluating tobacco intervention programs as a whole, but this one's looking specifically at the clients. So when are you going to be evaluating your client's readiness to quit or their progress in their tobacco cessation or reduction journey? So we are going to be evaluating, and this is setting specific as well. So in the emergency department, we would do it at triage and once they come into the department, and we would also reevaluate once someone is admitted on medical or on any inpatient unit. I think it's important to assess your client's tobacco use status at the beginning of admission, and just to incorporate it in your initial routine head-to-toe assessment, I found is something that can be effective. But if someone is going to be on a unit for a prolonged period of time, a discussion needs to occur on how often you're evaluating their tobacco use, and whether or not the program or plan that we have in place with them is working for them and is effective in managing their withdrawal symptoms. So that's something that would need to occur within each setting and occur with the patient as well. So just at the beginning of any admission, just finding out with their patient what their goals of care are, whether or not quitting or reducing their tobacco use is something that they would like to do while they're in hospital. So education recommendation, recommendation 5.1. Incorporate evidence-based content on tobacco interventions in healthcare professional education programs. So this recommendation was revised and is more encompassing of not only academic settings, but making sure that tobacco intervention education is included in all healthcare professional education programs, including orientation programs within healthcare organizations. So for any orientation for new staff, at least brief intervention education and education on withdrawal management and the harms from nicotine and tobacco should be included in any orientation program, especially with the January 1st deadline coming up. All healthcare providers should have this knowledge in order to support their clients while they're admitted in an acute care setting. So for employees who are already working within the healthcare organization, this can be done through lunch and learns, it can be done through in-services, and it can also be done through e-learn modules. So making it a requirement that all healthcare staff are doing required e-learn modules before January 1st so that they're able to properly help their clients. So recommendation 6.3, embed tobacco use prompts in health records or documentation to facilitate addressing tobacco interventions during healthcare visits. So this is really just to make sure that when we're doing our documentation, there's a space that's designated for us to document tobacco use of each and every client. So this will help just to prompt all the healthcare providers to make sure that this is something that they're doing in their routine practice. And this is something that every hospital organization need to be doing uniquely based on the type of documentation that they have at their organization. So a lot of organizations have already taken the first step and introduced it into their EMR so that when healthcare providers are doing their initial assessments, they'll be prompted by the computer system to document whether or not someone has used tobacco in the last 30 days, or I know some people have even incorporated the last 6 months within their EMR, and then also having areas to check off the type of intervention that was done after they were asked about their tobacco use. So this can even include, did you refer them to Smokers Helpline? And if the Smokers Helpline will pop up. Did you refer them to any sort of counseling or any sort of referral system that we have within hospital? Or even refer to, there can even be prompts such as, did you refer them to social work to work on the other aspects that are contributing to their tobacco use? And having anything like that, and that can help to reduce workload as well and to catch issues before they arise, such as people having severe withdrawal symptoms. I also wanted to point out that some people don't have EMRs, and a method that I've seen used is stamps or stickers. So if you're still using paper documentation, instead of going through the sometimes lengthy process of changing an entire paper charting system, I've seen people create just a stamp or a sticker where people can place a sticker on the front of a chart, and it can be checked off whether or not someone has used tobacco, whether or not they are interested in quitting, and the types of interventions that have taken place already to address their tobacco use, such as I've completed a medical directive and they are now on NRT. And I also just wanted to discuss medical directives as well. And I recognize that not all health care providers know what a medical directive is. So a medical directive are indirect physician orders used to expedite patient care by competent healthcare professionals. A medical directive applies to specific patient population who meet specific criteria. So the specific patient population and criteria, of course, would be people who use tobacco and are interested in managing their withdrawal symptoms or trying to reduce their tobacco use while they're in the hospital. So medical directives need to be interprofessional. You need to have the entire healthcare staff on board with the medical directive. It's going to be put in place. And medical directives in this context are typically used for the prescribing of NRT or nicotine replacement therapy. So this is especially important in acute care settings where you might not have continuous, easy access to a physician, and this is something that nurses or healthcare providers would be able to implement on their own in order to manage withdrawal symptoms before they occur. So sometimes I know you'll have a patient who's beginning to escalate and are asking if they can go out and have a cigarette or use tobacco, and it would be nice, or it's quicker and more efficient if we have access to medical directives and we can assess their tobacco use, how much nicotine they will need, and be able to give it, as opposed to waiting maybe an hour while waiting for a physician to get back to us and having the patient escalate even further. So just a further slide about that recommendation. So what resources do you have available? And that goes in terms of the paper versus the electronic medical record charting. Do you have a TI team? Do you have the financial resources in order to be able to implement something like this? Stakeholders, just having everyone on board so that everyone is aware of the medical directive, and the medical directive will have to be created by an interprofessional team as well. So going into the final recommendation, recommendation 6.4, so evaluate tobacco intervention programs and services. So this is looking at the implementation of the tobacco intervention program. So you're going to always ask yourself, once you implement any of these recommendations, how is the implementation going? Is the intervention effective and doing what we want it to do, which in this case would largely be managing withdrawal while in hospital or supporting our clients to quit or reduce their tobacco use? And what can we change or improve in order to make these things not only more efficient for staff, but more beneficial for the patients who are receiving any of these interventions? And why is evaluation important in terms of evaluating the programs that were being put in place? So if we do not evaluate, we do not know if our interventions are effective. It's also necessary for program improvement and an opportunity to re-engage stakeholders. So if we are able to evaluate and say that our healthcare providers are more knowledgeable about tobacco use interventions and therefore our patients have seen better outcomes, we've been able to have more people quit or reduce their tobacco use, there's been less scenarios of de-escalation due to the management of withdrawal properly, then we can bring that back to our stakeholders and celebrate the successes that we've had. So some tips and tricks for sustaining change in regards to the implementation of tobacco interventions into acute care settings is to make it meaningful to staff and patients. So that means really educating our staff and patients about the importance of tobacco interventions and how that can impact their care. And in acute care settings, that can be, this is going to save you time. If we're able to manage withdrawal symptoms of patients at the outset of care, then it might require less work for you later and less of playing, say, a catch-up game after someone's already having issues with their withdrawal while in hospital. This could also mean making it setting specific. So just to give you an example, patients who are in oncology units, if they're using tobacco during their treatment, it might mean that they have to use higher doses of chemo or radiation in order to have the same effect. So educating the staff and patients about things specific to their unit that could affect their patient care, as well as their treatment goals, that would be something that could help to sustain change within specific settings. So embedding the change into everything. So this is something that the smoke-free policy is helping us to initiate, and that is going to be changing organizational values and cultures around the use of tobacco. But this also involves the embedding the documentation into each site as well as having even just prompts around the unit. If you guys have posters or anything lying around that helps patients to know and hospital staff to know that asking about tobacco use is something that's going to be happening on a regular basis, then it's going to occur more often and it's going to become more part of routine practice. Also presenting the intervention as a task. Oftentimes the language we use helps to implement interventions, and brief intervention is definitely something that can be introduced as just one task as opposed to saying, well, you're going to now be counseling your patients on tobacco interventions, just to say, now this is just going to be a routine task that you're going to be doing at the outset of every assessment. Also being transparent. So letting the healthcare providers and the patients know why exactly this change in practice is going to be taking place, and even involving those healthcare providers or patients or any stakeholders in the decisions and the rollout of how these things are going to be taking place. Also to be empathetic toward one another's workloads. So this is an interchange between healthcare providers largely and management. So management just needs to be empathetic to the fact that in acute care settings, as well as in all settings where frontline or healthcare providers work, we're often strapped for time, and we're trying to do a lot with a little. So just being mindful of that in terms of the frontline healthcare providers, but then frontline healthcare providers also need to be empathetic towards management and the specific pressures that are going to be put on them as well in order to implement these changes before January 1st. Also wanted to take some time on some special considerations. So the consideration of withdrawal management and having these brief interventions at the start of any assessment or any introduction into hospital care environment is very important with people who have physical barriers to making it to off-hospital property. So these could include people who are incarcerated, people who are not physically able to make it off of the hospital property, and people in psychiatric holds. So just making sure that we have the infrastructure in place to be able to support these people as we transition to smoke-free hospital policies. I also wanted to note that the use of cultural or traditional tobacco use is still allowed on hospital property, but there needs to be some designated policies within the hospital regarding where these the cultural or traditional tobacco use is going to be taking place. So just so that everyone's aware that that's not something that's included within this legislation. Just want to quickly go over the long-term impacts of smoke-free policies. So smoke-free policies that have been implemented always result in a reduction in the number of people who use tobacco, reduction in number of people who experiment with or start to use tobacco, increased quit attempts, and a greater chance of trying to quit and stay quit. And then some positive changes long-term that have been seen with the implementation of smoke-free policies is improvements in child and perinatal health, which includes reduced preterm births, reduction in infants with low birth weight, less cases of asthma, as well as reduced incidence of cardiovascular disease, heart attacks, strokes, respiratory illness such as COPD or tuberculosis, the reduction in certain cancers, and improved overall population health. So what is to come? The Smokefree Ontario Act, there have been some documents that have been, or reports that have been put out recently, just that are beginning to look at the further expansion of smoke-free policies. So that could include smoke-free sidewalks or just global smoke-free policies. So the only place that this would be able to take occur would be in residences, as well as the introduction of cannabis legislation is they're trying to roll that out for the summer, so just to keep that in mind as well. And then just wanted to point out that there is a resource section as well as references that are going to be distributed along with the slides after the presentation. And then we've been asked by our partners at Smokers Helpline just to show you guys 2 slides on some of the restructuring that's going to be taking place or that has already taken place, just so that you guys know exactly where to be referring your clients to at the end of the brief intervention. So we have their website here as well as their phone number. So if you refer, you can just text I quit to number 123456. And the final slide, so these are the coordinators and their contact information and the specific programs that they're linked to if you guys need any information from Smokers Helpline. And that is it for me.
Okay, well, thank you, Nicole, for this excellent presentation. So we have about 10 minutes to take some questions, and I do see some in the chat box, but also just a reminder, if you do have any, feel free to put them in now. So I'm just going to go through some of these questions and then see if Nicole can answer the best of her ability. So there was a question, or maybe it was more of a comment in the beginning when you were going over what the effects, the impacts of this will be. And someone said, well, what about third-hand smoke and the impact on that?
So in regards to third-hand smoke, okay, I'm just going to click a slide back so that someone can see the last slide. In regards to third-hand smoke, this policy is particularly looking at secondhand smoke and smoking within the hospital settings. So third-hand smoke wouldn't necessarily be an issue. Third-hand smoke, for people who don't know, is any chemicals or residue that's left over in an environment after secondhand smoke or smoking's been taken out of that environment. So if we're eliminating secondhand smoke from the environment as well as tobacco use in general, within the hospital setting, third-hand smoke shouldn't really come into play.
Okay. And just because I know some people are asking, the slide deck is sent out to participants afterwards, after this webinar? Okay. So those of you that are wondering and wanting to see some of the slides again, you will get a copy of the slide deck. So you'll have all the resources and the links that Nicole had in her presentation. Another question I saw was, when will there be publicity of this new law, I guess, to the general public?
So I have seen healthcare organizations really bringing this onto themselves and saying, we are now a smoke-free organization. In terms of when the Smokefree Ontario partner, or the Government of Ontario is going to be rolling this out, I'm not sure. At this point, it's just been healthcare organizations promoting the fact that they're going to be smoke-free organizations. But I can't really speak to when the Government of Ontario is going to be doing that.
Okay, great. And the questions are coming in, so I just have to move up to see. So another question we had was, what is the difference between traditional and normal tobacco?
So the difference between the use of traditional and normal tobacco is the purpose that it's used for. So traditional tobacco use is a cultural practice, and with the thought of being culturally sensitive, it's not something that we can include if it's important to Indigenous populations and can help to improve their health. And the use of traditional tobacco is not for the inhalation, so it's not considered to be a harmful practice.
Okay, so more of a difference between why it's being used and how it's being used. So someone was also wondering where they can get the pocket guide when it's finished.
So the pocket guide, the current pocket guide that we have, can be found on the RNAO website if you go to our resources section. Correct? Yeah. But the new pocket guide, we're hoping to have it out in the next couple of months, and when that happens, we can send out sort of a press release that it will be available for purchase.
Okay, great. And then somebody's made a comment here, and important to think about. Nicole, I don't know if you can comment more on this, but for people who have disabilities or on a fixed income, there's no coverage for NRT.
Yes, I know. That is a really large issue. That NRT is so expensive, and that's just an added stress on anyone who's trying to quit or reduce their tobacco use. So the only thing that I can really say in terms of that is that there's a lot of programs that you can typically link to in order to get free NRT. So some of those programs, if you're a youth or young adult, would be Leave the Pack Behind. A lot of public health units as well offer quit kits and have access to free NRT for people who are on disability or who are not able to cover the cost of NRT on their own, as well as a STOP program also provides NRT to people who are not able to get it. So just knowing what resources you have available is huge, especially in the implementation of these sorts of policies.
Okay, and just to point out that Daniel and Audrey are explaining a little bit more about the the spiritual use of tobacco. So thank you for that clarification from the two of you as well. Yeah, so, and then there was a general question around continuing education credit certificate. So no, that is not offered through these webinars. When you do complete evaluation and there is a certificate that follows after, that is more for your own personal use, and attending these are more for your personal knowledge. Okay, and then someone has commented here that they are currently partners with Ottawa Model for smoking cessation. They provide us with quick cards up to $300 of value. Okay, and somebody else has commented here, for Indigenous people, they are covered by the NIHB. Well, thank you for those of you that are just providing some more tidbits of information too. Are there any further questions for Nicole before we end this webinar? Okay, and then somebody has shared a link, lung.ca, link to traditional versus ceremonial tobacco. So I think this is a really important topic that maybe some people will want more information on to help them understand the implementation of this law.
So in regards to the question, is this only for hospitals, not long-term care? Residential facilities are included separately in the Smokefree Ontario Act from psychiatric facilities as well as hospitals. So my understanding is that long-term care is separate in regards to this, this new policy, but it's something that I think we definitely need further clarification on, and something that I am looking into at present. Okay. So thank you very much, everyone, for attending.
And then, Nicole, you just want to tell them about an upcoming webinar if you haven't?
Correct. So just so everyone is aware, before we go, on November 28th, we are having another webinar. We're going to have a pharmacy presenting on tobacco interventions and the use of pharmacotherapy. So just so that everyone has it in their calendar, we're going to be sending out a registration link within the next couple of weeks.
Okay, great, thanks. So just a reminder to all participants, you're going to receive an email from RNAO within the next 24 hours. It's a link to a short evaluation survey. We really do encourage people to complete the evaluation because it gives us more information on how we can strengthen the webinars. And once you've completed the survey, as I mentioned earlier, you'll be able to print off a certificate of completion, and then this is really just for your own personal use. So thank you for being a great audience, and we hope to see you at the next webinar.
And these slides are going to be distributed with the evaluation link.
Right. Okay. Thank you.